my first time lecturing in SOC. So we'll see how it goes as to whether that affects the quality. So I'm going to move through this fairly quickly. Conceptually, the issue is that we have a massive amount of data. And how do you end up molding this into a consultation, an initial consultation with the patient, as far as all the things that you need to cover and think about? What is the practical approach? Because you can do all types of weird and wonderful things, but I think those should come much later. But basically, a little bit about me. I already told you guys a little bit about me in the previous session. So I've been studying for a long time and do a lot of interesting things, but now I'm much more in the longevity space. So as far as what we do with the longevity medicine consultation is that we want to take a look at what the range of possible is, but then sort out what to actually do. So we want to focus on modifiable issues. We want to focus on the individual and their risk profile, their genetics, so forth, as far as what's likely to cause them harm. But then not get distracted by that, because your genetics probably are only about 15 or 20% of your health outcomes. The rest of it's going to be lifestyle, other factors. So if you focus too heavily on that, then you end up missing all the usual things that kill and harm people. And you want to make sure that you're not ignoring that. So going through this, I like going through it as a very morbid approach and go, what's going to kill people? What's going to disable people? So as far as killing people, it's going to be vascular disease, cancer, accidents, infections, stroke, infections, usually in people that have lung disease or elderly, Alzheimer's disease, diabetes, kidney, liver disease, so forth. Then as far as things that disable, which is probably something to focus on, is going to be, it is going to be cardiac disease. It's going to be stroke. Those are big factors. It's going to be malignancy. It's going to be trauma. All these things that end up resulting in disability. So I go through this and go, how do we mitigate these risks? Every one of us is going to die. The issue is sorting out how to prolong quality length of life, and then secondarily the total length of life. So what I look at is I actually mold domain 1, 2, and 3 together, which is basically going to be coronary artery disease, stroke, another vascular disease, metabolic disease, malignancy. And the reason why I put those together is because my strategy around those ends up overlapping massively. So it's kind of saint preventions. So optimizing people's lipids, their homocysteine, their omega-3 index, blood pressure, insulin sensitivity, diet, exercise, visceral fat, don't smoke things, obviously. And then take a look at genetics. If somebody's got premature coronary artery disease in their family, do a cardiac test and take a look and see if they have genes. There are some genes that are essentially 100% predictive that you will have symptomatic coronary artery disease by the time you're 50 if you're a male, or 60 if you're female. 9p21 is the worst of the genes, but there's about 20 of them that end up impacting risk. So I think that, in those patients, I do that. It's important to recognize that for malignancy screening, because, I'm up to date, I've had this, that, the other screening. Only 30% of malignancies have a screening test. 70% do not. And of those 30%, your screening test only picks up a portion of those.
Take mammography, for example. It does modestly decrease breast cancer death rates, depending upon the group in most studies, but ends up failing to prevent the majority of deaths. Colonoscopy is possibly a little more successful in decreasing bowel cancer deaths, but still fails in a high % of cases.
So my strategy with this is that anybody who's got a little bit of age on them, anybody who's likely to have coronary artery disease or disease in their brain or malignancy, which all of us are at risk of, especially, as you get over age 50. But more so, we're seeing, especially in women, actually, interestingly, over about age 35, we're seeing a big increase in malignancy. It's not entirely clear why. But getting a CT coronary angiogram, it's not very expensive, pretty specific, and it will tell you if you have disease or not. And if you have disease, you're going to be more aggressive with your lipid treatment. You'll be more aggressive with a whole bunch of things. A lot of people that have bad lipids and kind of go, I'm not going to treat it. A lot of them, when we scan that, they don't have significant disease in the heart. But when we do an MRA of their head, they've got extensive white matter disease and saying this is basically eating away your brain. And when people get aware of that, it's much more motivating to say, hey, let's treat this before you have progression. So, and as far as malignancy goes, I usually use the SimonOne. They have an office in San Francisco.
They have offices in 9 different states. is $1,250 for a whole body MRI with an MRA head and neck.
And that gives you a lot of information. They use 3T magnet. You're down to 1 millimeter resolution or less, and they'll pick up little things. So I see people when I work in the ER, that emergency position also, who come in and they've got belly pain and they're a little yellow, and I know what I'm going to find. I get a CT and they've got stage 4 pancreatic cancer, and they're maybe going to be 3 months before they're going to be dead, and I get to tell them about that. If those people were my patient doing what I recommend, that would have been found when it was tiny, would have been a simple interventional radiology biopsy and a cure, and no need for anything else. So this is something where there's a real benefit to taking the strategy. So that's basically my strategy with, those 3 conditions, which are, that knocks off a lot of, that's most of your risk of death and disability right there. Looking at infections or big factor, as you get older, infections are actually number 2 killer, but it is something where it is confounded. It's like, last time I admitted a patient for COVID, because of COVID solely, has now been almost 2 years. And I do high volume urban ER. So something where, but you'll see people get COVID, and it's the one thing that pushes them over the edge when they're frail, which is a good reason not to get frail. And make sure that you keep your muscle mass up and you keep fit, because then you run down, and all you need is you just need one little insult and you tip over, and you're done. Same thing, a trauma, sarcopenia, osteoporosis, frailty. There's strategies to avoid and also treat the osteoporosis. Make sure to monitor, get a DEXA scan, and then be smart as you get older. It's like, hey, I'm almost 60. I can climb up a ladder, no problem, clean my gutter. But if I fall off at my age and get a broken hip, so that being the slippery slope that ends up leading to my death is significant. Where if I was 18 doing that, you're going to be fine. So it is something where you need to really pay attention as you're getting older to make good decisions about risk taking, so you don't get hurt. You see a person get the hip fractured. Okay, now they get an infection afterwards. They get a PICC line in. Next thing, they form a blood clot on it, and next thing they're on blood thinners. Now they bonk their head and they got a head bleed. It's just like the spiral down at medical misadventure. That's why you don't want to have any contact with doctors. So neurocognitive decline, this is an area of interest for me. I have a YouTube channel, Dr. ApoE4, go through the things that are going to decrease your likelihood of getting neurocognitive decline. And there's a lot of things in this space. It's massive, but it's a specific thing to be addressed, and it's reasonable to be taking a look and monitoring these conditions, doing neurocognitive tests for people that are willing. A lot of people just don't want to know. But for some of the patients, they'll kind of track it over time.
I use CNS Vital Signs, which is a great product. It costs $35 for the practice, and after administration fees, I usually charge patients $50 for this comprehensive test online.
And then big things also is, as far as timing of therapy, we talked about this with rapamycin, and I didn't chime in on this question. As far as timing, I would say that for especially neurocognitive stuff, you're going to want to start 20 years before you are going to have anticipated symptomatic disease where you get a diagnosis, because with Alzheimer's or Parkinson's, you're going to have at least 20 years of neurodegeneration before you actually get a diagnosis. So with Alzheimer's, you'll have about 10 years before you get a diagnosis. You'll have mild cognitive impairment, which is kind of like, you notice that there is a problem, but other people might not notice it yet, but it's starting to drift away. So you're going to want to start before there's brain disease, and that's a real problem. And there's a specific indication, I think, for rapamycin with people who have ApoE4s. But then the reality is that 42% of people 55 years of age or older right now are estimated that they're going to have dementia before they die. So it's not only people with the genetics; it's everybody. Something to actively manage. Hormone normalization for life is another thing I go through. There's very few contraindications, there are some, but I end up optimizing male and female hormones. Make sure thyroid's taking care of adrenal hormones, and then HGH or analogs of that are things that we consider in people that have a low IGF-1. Then there's all the stuff more functional medicine area with diet, exercise, sleep, stress, community engagement, environmental. Have you been exposed to molds, metals, organics, plastics? We need tests for that and address that. Chronic infections are a big issue, exactly as in the last lecture in gut health. those are things that need to be addressed. Periodontal health is a huge issue. You end up having poor periodontal health. You'll end up having an increased rate of dementia, an increased rate of coronary artery disease. So something where very reasonable. I kind of have my protocol here as far as what I recommend people to do. Nitric oxide optimization. So it's a good thing for the heart, but also a good thing for erectile function as men age and have problems. So, and then mitochondrial optimization. We do discuss things like rapamycin, methylene blue, NAC, ethyl ester with glycine, and senolytics. So I'm not completely sold on Zipanib. I think it's a little bit indiscriminate. But I do have some patients who I've inherited that are on this, and I'm not, and they feel that it's good. I don't usually start people on that. Then there's supplements. There's a whole bunch of things there. I think the big thing is that pick out your key ones. Don't do 100 things because it may be counteracting. Pick out ones that make sense. And then I think as far as pharmaceuticals, rapamycin, SGLT2 inhibitors, which like Jardiance, Farxiga, so forth. GLP-1s, take a look at, community surveys, and it's not double blind controlled, but it is something where people that are on SGLT2s and GLP-1s simultaneously, it's like a 70% decreased incidence of Alzheimer's dementia in those patients. Telmisartan also, if anybody's on blood pressure medication, that should be the first one. Whenever I start somebody on blood pressure medicine, or if I inherit a patient, this will be something where, and it's the only blood pressure medicine I push to the maximum dose because that's where you get the gamma PPAR activation with this, which improves insulin sensitivity, improves brain health. So it's a unique agent. The carbose is reasonable, especially in combination with rapamycin. We saw more longevity with it. Metformin's question. I think that there may be some benefits, but there's also some risks of muscle loss with that. And then, we mentioned methylene blue for optimization. So that's the talk. That's my approach, and I get through about 70% of that in a 60-minute consult with a new patient, and then we have a bit of stuff left to tidy up. Is how it usually works. Any questions?
Yeah, let's say 2 or 3 questions.
Yes, I have a question. I mean, you said with routine screenings, the rate of death reduction is great, and I think I've seen that too.
Yeah.
And then you recommended like full body MRI, which is somewhat controversial, I guess. Like, why wouldn't we expect that if we did a study, we find that full body MRI also didn't reduce death?
I don't think that we have data on that, but I think it is something where stage 4 malignancy, which is how it is almost always diagnosed when it is based on symptoms, has a very high rate of being fatal. We know that early on, those are almost completely curable, and the MRI has a high sensitivity. It'll miss some bowel cancers, but as far as like other things, including does pretty good job on lung. It's not as good as high resolution CT, but does a pretty good job on lung. It's going to find stuff when it's small. And we know that if it does that, we know from other experience that early detection of things where it's stage 1 has a much better health outcome. So I think you can by inference, but no, there's so many things that I do where I go, there's not going to be a study showing this to be beneficial. Here's the logic on what I'm going on. But if you want to wait for a study, we'll both be dead by that.
So, yeah, and I kind of go both ways. So that's right. Like, it's really hard. Okay, that's safe.
How often would you say, what's your optimal frequency for a full body MRI?
Yeah, so what I do with this is if somebody has an abnormality, I'm going to want that area, depending upon what the abnormality is, typically a one-year interval. And then as far as just on a cost-effective basis, if I have somebody who's not a heavy drinker, who's not a smoker, who has a normal head and neck,
I recommend at an age 50 to 60 years old every 3rd year, and then age 60 years plus every 2nd year if it's completely normal and they don't have risks for forming a malignancy in their head or neck.
So the body scan zone, as SimonOne, is $650. So it's like half the price. So doing the body every year, I think for most of my patients is affordable. And then just strategizing based on their scan results and their age as far as, so that's been my pattern. I don't have any evidence behind that, but that's what I've been doing. Yes.
Huh. What was the name of the place? The scans, and is that something you need a doctor for?
You do not. This is their only self-ordered scan, and their staff is a little bit mentally challenged some days with this, and they'll say you need a doctor's order, and it's like you need to remind them, no, this is your one scan where you do not need a doctor's order, and it's called SimonOne, and they do have a center here in San Francisco. They have a couple in Southern California.
I come from the movement. I'm at that. Yes, I'm at.
Yeah. Yep. So yes.
You didn't mention carbon monoxide.
I didn't mention carbon monoxide, and I guess somebody would have to have a risk for exposure for that.
Well, there's an optimum with carbon monoxide. It's not something you should have none of. In fact, you'll die.
So I guess as an emergency physician, I've never seen somebody die of that condition.
There's no growth without carbon monoxide.
So interesting fact. So no, it's not something where I'm measuring or optimizing in my patients. And same thing goes. I think one of the more important items that I would mention that we didn't mention has to do with radon. I think radon is an important thing that everybody should grab a meter and see what it is in their house, because it is the number 2 cause of lung cancer, and it's something where, especially if you're anywhere around granite or rock, it oftentimes will seep in. And you'll have no idea that you're and as soon as you inhale this, it's there for the rest of your life, continuing to be an increased risk of cancer. So that's one of the things I also recommend. That's one of the environmental things I actually forgot to put on the slide.
All right. Thank you very much.